The talk given to me is understanding glycemic control in diabetes. See, basically, glycemic control remains a delicate balancing act. The diabetic patient is tasked with maintaining euglycemic blood glucose levels and a goal which requires education, decision strategies, volitional control, and the wisdom to avoid hyper and hypoglycemia. You have the glycemic triad. What is the glycemic triad? You have the fasting blood glucose, which is your basal glucose level. You have the postprandial glucose level, which is the peak glucose level. And you have the HbA1c, which is an average level. It's the weighted mean average of the fasting and the postprandial. But beyond the glycemic triad, you have the glycemic pentad. What does that have? Besides these three, you have glycemic variability and you have hypoglycemia. This completes the glycemic picture for a type 2 diabetic or for a diabetic anyway. Now, what is the importance of each of these? Fasting glucose and cardiovascular risk, the Framingham Heart Study has shown that as the blood glucose rises, the chances of myocardial infarction and cardiovascular disease increases. And once you have diabetes, it increases manifold. This is a prospective study done over 1 million Koreans, followed up for 16 years. And what did they find? That as the fasting glucose increased to more than 100, the risk of cardiovascular disease, ischemic heart disease, myocardial infarction, stroke progressively increased. That was as far as fasting is concerned. Postprandial and CV risk. See, whenever you talk of the postprandial glycemia, as the HbA1c keeps coming down from 10 to less than 7.3, you find that the postprandial glucose has the greatest effect on the HbA1c. At a HbA1c of more than 10, it is the fasting which has a greater effect. There are studies which have shown, this is the Honolulu Heart Study, which shows that as the blood glucose rises, the chances of coronary heart disease increase. This is the DECODE study again, which showed that increase in postprandial glucose concentration even in subjects with normal fasting glucose. Remember one thing, that the postprandial is the first to increase. The fasting rises much later. And that these patients were associated with mortality independent of the fasting glucose concentration. So postprandial glucose is a risk factor by itself. Now HbA1c is a risk factor. N number of studies have shown it. I'm just selecting a few because of shortage of time. The EPIC study shows that as the HbA1c increases, the cardiovascular risk increases. This is again the other study which shows UKPDS, which shows again, as the HbA1c increases, risk of coronary artery disease increases. Then we come to glycemic variability. What is glycemic variability? Look at this. You have wide excursion from the peak to the nadir, but still the HbA1c is 7. So if you just look at the HbA1c and don't look at the variability, it's a good report. But when you look at the glycemic variability, this is a bad report. What it should be is like this: a steady, no peaks and nadirs, and that would be a good glycemic control. Now, when you talk of glycemic variability, it has been described that within day variability, means during the day, in one day, he could have peaks, nadirs going on. It could be between day. One day he has a good report. Are all variabilities, and this glucose variability is not reflected in the HbA1c, and thus could possibly represent an additional risk factor for the development of complications. So there were certain studies done. Most important issue in clinical practice is whether glucose variability contributes to morbidity and mortality. And this was looked at in pediatric ICU, critically ill patients in the pediatric ICU. And there were studies done. All the three groups concluded that glucose variability measured as a standard deviation was a significant predictor of mortality in critically ill patients. I repeat, critically ill patients, independently from the severity of the illness. These are other two studies which again looked at pediatric ICU patients. Both these studies confirm that glucose variability is associated with mortality and increased length of stay in the hospital. But that is not the whole study. Glucose variability and microvascular complication, DCCT, which is a big study done in type 1 diabetes. And they, in fact, measured glucose profiles, 7-point laboratory measured glucose profiles every 3 months over 6.5 years. And what did they find? The glycemic variability did not influence the development or progression of retinopathy or nephropathy. Only the mean glucose, not its instability, predicted the risk of retinopathy or nephropathy. So we have conflicting. That earlier one was in the critical ICU patients. This is a large study over 6.5 years. Follow-up of that study again in the EDIC. What did they find? Glucose variability in DCCT did not predict the development of retinopathy or nephropathy by EDIC year 4. So it is a bit, you have to take it with a pinch of salt. However, at this time, there is no supportive evidence for targeting glucose variability. But at the same time, I would add that today we have drugs which can help you give a good control of the glycemic variability. It would help. Hypoglycemia, most important, and it is the rate limiting factor in treatment of patients with type 2 diabetes. If hypoglycemia was not there, probably you would not need diabetologist at all. Everybody could just treat and go on. And hypoglycemia can induce mortality. And the reason or mechanism shown is increased heart rate, silent myocardial infarction, angina, etc. And once a patient gets hypoglycemia, then he's always tense. And there is a defensive eating. And because of that defensive eating, his glycemic control goes for a toss. So that is another aspect of this hypoglycemia. Now, there were recent large randomized trials looking at intensive glycemic control, your advanced, ADOPT, BADT, ACCORD. These were stopped because of increased mortality, the ACCORD study. But one thing, the cause for mortality in the ACCORD was not clear. And hypoglycemia has not been implicated as a cause of death in these cases. Very important to note that. So to conclude on this, the fasting, postprandial HbA1c, hypoglycemia, and glycemic variability are the different faces of the same coin. And that coin is glycemic control. We need a good glycemic control. You look at it anyway. And evidence regarding the effect of intensive glycemic control in type 2 diabetes is contradictory. We have had good reports. What we have now know is that early meticulous control, as shown in the UKPDS, could prevent CVD many years later, metabolic memory legacy effect from the UKPDS. Type 2 diabetic patients with known CVD or a long duration of diabetes may be harmed by intensive control. That is another thing. Very tight control can cause problems. The UKPDS showed that getting the HbA1c down to 7, in fact, over 10 years, HbA1c was 7, and in the intensive group, it was 7.9. By bringing it down by 1%, you have a very significant improvement in microvascular complications and to some extent in the macrovascular complications. So HbA1c less than 7 was what Wikipedia showed, and all the guidelines followed suit. Look at this, the 2006 ADA ESD guideline. It talks only of HbA1c. Lifestyle intervention in metformin, if HbA1c is more than 7, then you add this. If it is less than 7, you don't do anything. So HbA1c 7 became the gold standard. But UKPDS was only in healthy, newly diagnosed patients less than 65 years old. So then came major studies in real-world population. The ACCORD Advanced BADT, it did not show any benefit except for microvascular complications of nephropathy in ACCORD and Advanced. ACCORD showed increased mortality, weight gain, and hypoglycemia. So the message, which Dr. Manoria also showed, that you could have a good HbA1c, but still have a myocardial infarction. This is the Nurses' Health Study, which in short told us that elevated risk for cardiovascular disease begins 15 years before the diagnosis of diabetes. So it is not hyperglycemia alone which is there. It's the cardiometabolic risk factors. So overweight, obesity, abnormal lipids, age, gender, inflammation, hypertension, smoking, inactivity, and basically the insulin resistance syndrome. This is what it is. Now we have 6 oral anti-diabetics and 2 injectables. Your target is to get good glycemic control. All these drugs can do that. Preserve beta cells, durable glycemic control, only a pioglitazone does it. Treating insulin resistance, pioglitazone and metformin. Should not cause hypoglycemia. Only two will cause hypoglycemia, sulfonylureas and insulin. Should not cause weight gain. SGLT2, GLP-1 are good. Metformin and DPP-4 are neutral. Renoprotective, SGLT2, DPP-4, pio. CV benefits, metformin, pio, SGLT2 and GLP-1. These are the drugs. So what would be a approach to these patients? See, Indians are insulin resistant. We developed 10 years earlier diabetes and we have worse complications. And what do we need to do? We need to reduce peripheral insulin resistance, preserve beta cells, and you don't want hypoglycemia. These are the drug combinations which you have. A glitazone, metformin, which will address peripheral insulin resistance, preserve beta cells, DPP-4 inhibitor, GLP-1 analog, SGLT2, no hypoglycemia. And it could be a deadly combination. If these don't work and you still need a support, you could go in for a sulfonylurea. If you have only a postprandial hyperglycemia, alpha glucosidase inhibitor is there, and finally you have insulin. This would be a working algorithm for the management of type 2 diabetes. Thank you very much. I think I have just done it on time. Thank you.